18 years of meniscal transplants, and I can tell you at Mac, I certainly don't think the guys are doing that right now. And they may have done one maybe at Mac. I don't know if Femi's done any, but I know the guys at the General haven't. So I guess my first thought about this, because I don't do this, I'm a trauma guy, and who's the ideal person? I know there's a recent systematic review looking at some prognostic factors for meniscal allografts. Maybe you could just speak to that briefly. Who's your ideal person, and who would be the ideal first case if someone decided to do this, just out of curiosity? And then I think we should talk about graft choices. But
okay, yeah, I'm going to take that, Octavio. The ideal patient is a patient that obviously had a meniscectomy because of a bad meniscal tear. Somebody that has very little cartilage damage. It has a knee that is stable and that is well aligned. That would be the perfect case. Somebody with young, on their 20s or 30s, that has this kind of injury, and for sure it will require to have a meniscal transplant in order to have a better chance and prognosis of that knee, because we know for sure that they are going to wear if they have a knee without the meniscus. We say that the meniscus is to the knee what the thumb is for the hand. So it's that important. That's why if you have a bad meniscal tear, take the meniscus out and think about putting a new one. I don't know if that I answered your question.
Yeah, absolutely. And what are some of the things in your experience of 18 years are favorable prognostically? So we talk about the best patient would be young, minimal previous surgery, minimal loss of cartilage. What are the factors, though, that account for longevity of implant?
You want to answer the question? Okay. Yeah, somebody that has very minimal wear of the knee. Somebody that has an outer beach grade 1, maybe outer beach grade 2. Having said that, grade 3s and grade 4, outer beach grade 3s and grade 4 have more pain relief after the meniscal transplant, because they are in so much pain because of the wear and tear. Then when you place some tissue inside of the knee, that will improve the pain. So even in those cases, if you feel not comfortable putting a total knee because of the age, you can perhaps, another option will be to do a meniscal transplant.
So you would, Carlos, I see you, you would, I'll ask this question and then we'll get Carlos to ask a question. So you would do this almost in keeping with an HTO kind of thing, with someone's got arthritic changes to push off the total knee.
Right. What we will do is, if you have a viral deformity, we'll do a HTO, and that way we can correct the deformity, and then we do a meniscal transplant. Now, you have to plan that very well, because as you're going to be doing a cut on the bone, your sutures, you're not going to be able to anchor it. So probably what you're going to have to do is a bone bar to put it in, and then do your high tibial osteotomy lower than that. I don't know if what I'm telling you makes sense.
Yeah, no.
But if you are doing somebody that has a valgus deformity, you could do distal femur osteotomy in order to correct that deformity. Actually, I learned how to do those ones at St. Joe's and McMaster, and doing the chevron technique, and where you put your DCS, and then use the DCS to correct the deformity. And since you have the chevron osteotomy, that will collapse the medial aspect and correct the deformity only with the plate.
That makes sense. I saw a question from Carlos Leo.
Yeah, Brad, can you hear me there?
Yes, yes, sir.
Okay, first of all, congratulations to Edmundo and Octavio. We both had a good experience, and they invited me to be part of the book that just came out this year. So thanks a lot. And Mohit, congratulations on your new presidential position. I just wanted to comment a little bit on your question, because I think it's important of what Edmundo and Octavio has just said. We've been doing this for 2 decades and planning it for 2 more. We're sons of orthopedic surgeons that used to have those trophies that Octavio was talking about. I mean, the more meniscus you got, the better surgeon you were. So it changed a little bit from when we started with Edmundo doing the first meniscal transplant in several parts of Latin America, from Mexico to Ecuador and Colombia. And then we ran out of patients, Brad, because the perfect patient was gone. I mean, you don't have those meniscectomies anymore. We don't do that anymore. So the big change, I think, Edmundo, in this years, after we started having patients that were in the 40s and 50s years old, and these patients were starting to have pain, and they did not have a big angular deformity or a major osteoarthritic knee and started to have pain. And now the patients are different. Now we know the prognosis of what Edmundo is calling the thumb of the knee. We know that we have severe injuries from ski, severe injuries from football, severe injuries in really young patients that are losing a long portion or part of their meniscus. And those patients, we have to look a lot and check them out. And as soon as they start having the minimum symptoms, or we can have some predictive factors for early osteoarthritis, these are the guys that are perfect. Because, I mean, the perfect guy, as you asked, is the guy who has no angular deformity. One of the big mistakes is trying to compare meniscal transplantation with a partial knee replacement or an osteotomy. It is more compared to what we can do with arthroplasty than an osteotomy, because angular deformities kill the meniscus. Right. So I think that the big thing now with transplants is the second wave, and the second wave is prevention and trying to learn that in those patients that we have huge meniscal injuries that we cannot save, or a failed meniscal suture, we have to be very aware, because they're good candidates for a meniscal transplantation. I don't know if you agree, Edmundo and Octavio.
If I can chime in before you answer that, Edmundo, because I was thinking that exact same thing as I was listening, you know, and I was thinking about my last 22-year-old with that big Schatzker 4 medial, you know, where the femoral condyle goes in. And we were having a case discussion on that. I said that the primary thing about that operation is pulling the meniscus out, and it's always in there. But I'm not astute enough to be following them for this meniscal stuff. And to Edmundo then, and to your point, Carlos, when should I be looking for that patient to become symptomatic enough to even think about a meniscal transplant, or are they a candidate?
Well, like I said before, I'm sorry. Like I said before, you know, yeah. there is a question still if you should do a prophylactic meniscal transplant.
Well, and I fixed them all, but you're right. Should I be doing a prophylactic transplant?
Well, if you are left with a knee that has a very torn meniscus that you know for sure that it's going to fail,
yeah,
why should you wait?
Yeah.
You know the clinical history. You know what's going to happen. Therefore, perhaps we could do on those particular cases where you have an unrepairable meniscus, move forward, take it out and discuss with the family, get a good tissue from the bone bank and do a meniscal transplant.
And so you mentioned good tissue. There may be some prognosis with respect to the type of preservation. In your mind, what's the best? Okay,
fresh frozen.
Okay.
Yeah, you should not use those. I can't remember the name. When you take all the water out,
cryopreserver, lyophilized.
Lyophilized. When you have a lyophilized tissue, that's not going to be very good for the knee. You have to use a fresh frozen tissue, meaning that when you have somebody that died, passed away, and you do the harvest, you put it, you take the meniscus out, you put it into a bag, and get frozen, and that way, when you get it back, that tissue is going to be a very good scaffold tissue where synovial tissue, synoviocytes type B, will get into the meniscus. And those ones are going to become chondrofibrocytes, and with the future, they are going to become chondrocytes, and they are going to produce lots of cells around the meniscus, and you will have a meniscus with cells inside. So because of what Rafael Inigo, that must be somewhere, has described, the synovial tissue will cover the meniscus and will give blood supply to an areas that we thought that will never get supply in the future.
Mm. And what's the number one meniscal related complication that you see? And I don't mean, post-op infections and stuff, but what's the number one sort of technical related or meniscal related complication that you see coming back that's potentially avoidable surgically?
Meniscal protrusion. Mm. When you have a meniscus that protrudes outside, it's as bad as having a meniscectomy.
Oh, really? So it's protruding out.
When you have a meniscus that is out, there is only one reason to have that. That means that either the anterior horn or the posterior horn is torn.
Oh, okay.
So you might have lost the fixation on that meniscus.
Oh, okay.
Let me jump in. Let me jump in for a second, if I could, Brad. So there's going to be trainees. There's going to be docs who aren't typically using this approach, right? This is a fairly novel. I mean, you can say novel, but it isn't novel. It's novel for those who don't use it. And you're talking about the possibility of a realignment, bony procedure surgery on top of another, technically challenging to some degree transplantation. You might have surgeons who might say, well, you know what, in that patient population, I think I would just go ahead and either give them an injection and then just wait for a total knee, because I can do that very quickly. I can do it reliably. What is your argument for the docs who say, listen, I'm just going to do a total knee replacement. It's much more predictable. There's less risk for me. The learning curve is less. Are they just different populations completely, that the patient getting a total knee is not the patient who's getting the meniscus? How does this fit into the overall algorithm of the, quote, general orthopedic surgeon who's trying to optimize care of patients with knee arthritis, let's say?
Yeah. I'm gonna go ahead and answer this. Patient that's gonna, in the cases that Brad said about the post-traumatic arthritis, the grade 4 Schatzker, that is usually some person like really, really young, probably like in his 20s. He fell down a motocross, I don't know, or a vehicle accident. So those patients, you don't want to have them with a total knee replacement. Right. It's a really, really headache to have to make revision surgeries, because obviously the total knee replacement has some time. It has to last some time. You have loosening, aseptic loosening. You have the wearing of the polyethylene. So that's stuff you gotta worry about. And every time you have to do a knee surgery, a revision of the total knee is going to be more complicated. You have torn ligaments on the sides. You have metallosis. You have debris. You have osteolysis of the femur and the tibia. So it's going to get harder every time. It's going to be really complicated surgery. And with a meniscal transplant, it's like a relatively simple technique. As you say, it does have a learning curve, but it's relatively simple. You could use the Amen devices that we have in the normal ACL kit to do the surgery. And you can, when the meniscal transplant fails, you can always have a total knee replacement, but a primary one, a non-complex one. So I guess that's the best probably the best idea where to try out a meniscal transplant. And the other thing you were talking about, well, it's not that they're different population. Possibly for the people that they're trying to do their first meniscal transplant, you should look for the ideal candidate or something like really similar, and then scale up your degree of complications of surgery. Like we've done high tibial osteotomies plus a meniscal transplant, or we've done osteochondral allografts plus ACL plus meniscal transplant in the same time. So probably you can say you can like up your game if you're on your learning curve.
Right. Right. No, fair enough. And let me ask this: what's the role of biologics? I know that some of you are pretty adept at all the different biological treatments and therapies. How are biologics being used in conjunction with management of this patient population?
Yeah, I'm sure that Carlos is going to jump in. And when
I look like a cell.
Okay,
Go
we
ahead,
just
Mundo.
lost a window. I don't know.
You're muted. You're muted.
Yeah,
Mundo.
I'm sorry. I'm back. I'm back. When you have a meniscal transplant, we did a study on sheep where we divided in two groups. One will become the donor, and the other group will become the receiver, and so on. And on half of the sheep, we apply growth factors. And what we seen when we apply growth factors, and I'm talking plasma growth factors. And what we seen is one of the things that happened to a meniscal transplant is it will get some shrinking. What is the problem? Well, you're going to have some blood going in, and that's going to produce fibroblasts, and they are going to deposit fibers, and they are going to produce meniscal shrinking. When on those cases when we apply growth factors, the phenomena of meniscal shrinking was not present. And was not present because they mediate the inflammatory reaction, and so it will recognize that tissue as their own instead of trying to destroy it. So it's always a good idea to apply growth factors in the young to have a better result on a meniscal transplant. So I don't know if that answers your question.
Yeah, it's very helpful. And I'm sure Carlos might have some additional thoughts.
Can I jump in?
And then Fernando after you. Yeah, please. Yeah.
Sure, that we've always tried to use it because it's biologically logical. It's a large surgery. It's a new implant. It's a foreign body somehow. We learned from Scott Rodeo that we should use in meniscal sutures fibrin clot, and just use that clot over there. And then after that, the PRP came around, and then after that, the stem cells came around. What we have learned over the past 15 to 20 years is that if you use this augmentations of biologics in the moment of surgery, most of the effect will be just gone because of the inflammation inside the knee. The whole swelling, it will go everywhere. You know, both the stem cells and the PRP go where they're being called into work. And if you have a large transplant or something like that, then you might have trouble. So the tactics have been like Fernando Radice that I saw around there somewhere. When we use it in ACLs, for example, we have to repeat that 3 months, or I mean, at least 6 weeks after, and we have better results just using them 6 weeks after. So you have to think, what do I need the biologics for? And one of the reasons is the mechanical stimulation for healing and shrinkage, and the other one is cartilage by itself. So in both of those scenarios, right now, the trend is to use them 6 weeks to 12 weeks after surgery, and not in the moment of surgery, because you have a lot of investment trying to put all these cells together, and then in the end, you're going to find that there's no big effect, and they will go somewhere else.
Hi, Piru.
Hi, Piru.
Hi, Piru.
Yeah, she's the owner.
So
And,
Carlos,
and to answer the other questions, if you may, if you let me do something, I really think that most question is clue, because we don't compete really with the total knees. Those patients are different. I mean, as everything in medicine, if you have a good indication for good treatment, you get good results. In the beginning, we found that we were doing patients with meniscal transplantations that did not fill 100% all the requirements. So we were doing more certain patients that had some degrees of osteoarthritis, and we found that the pain was gone. So it was good for pain. So there are like two kinds of patients: the patient with osteoarthritis and big cartilage damage, and then you have to think about that what you mentioned, which is let's think about just waiting until this total knee, which is for pain. We can wait for that. But what if you have a real athlete in his 20s and 30s? You cannot even think about that. And you have a meniscal lesion, you have a fracture, you have a multi-ligament, and then you end up with an empty compartment, and that's like the perfect patient. So those are two kind of populations that are different. And you get rid of the pain, and you get rid of the progress of osteoarthritis, and those are the two groups. And you have the older ones or the younger ones on the both sides. But there's always a good indication certain patients. We've done patients with 22, 23 years old of age, and we've done patients like 60, 62 years of age that are, the rest of the compartments are perfect, and they're just starting to have osteoarthritis, and they're young, they're still athletic. So these are people that really need something. It's not a matter of age, it's where, it's the cartilage depth, and then the indications, and you just have to measure risk and benefit. That's all.
It totally makes sense. Thank you for that. Fernando, you had a question.
Okay, can you hear me?
Yes.
Yep.
Yeah, so I'm really intrigued with the whole meniscal transplant, but I also wanted to ask, what about the post-op? What do you do to on the follow-up? Do you do an arthroscopy, MRI? How do you measure the good results in both of the groups? I mean, if you take the pain away, well, that's a good result. But what else do you take into account?
Okay, the thing here is that you have to be very careful. They cannot do deep squat, not until after 6 weeks. You gotta protect that knee, because the meniscus is going to attach to the external aspect of the tibial plateau, the capsule around, or where the meniscus was, and that takes good 6 weeks. So they cannot bend the knee to more than 90 degrees. We don't let them apply any weight for 15 days, and then we progress to full weight at 6 weeks. And no deep squatting for at least 6 weeks. You have to be very careful on that. After that, we can start progressing the amount. Like you said, there are some studies with the MRI that will show how the meniscus is changing from white to black again, and you can even see the circulation going in again. That's what Inigo describes as the tide wave of the synovial tissue covering the top of the meniscus and getting some of the vessels inside of the meniscus. That way you will have circulation back in that new tissue.
And still, you have some scores, knee scores, like the IKDC score, to evaluate the pre-op and the post-op, and you can evaluate them at 2 weeks, 6 weeks, 12 weeks, and then you could do it at the 6 months and 12 months post-op. That's kind of like something that's more that you can count in points.
And
we have to follow our patients with any transplant for 7 years. So that's the law here. You have to, anytime you put any implant from anyone, a donor, just like in kidneys, we have the same law for retinas, or for corneas or for meniscus. And practically, to answer your question, what I tell my physical therapists is, think about the worst case scenario of a meniscal suture and multiply by 2. And that's what you need. So if you have 3 weeks of non-weight bearing for 2 weeks, and you make it 4, 6 weeks of this exercise, make it 12. So it just make it twice as big as the worst meniscal transplant. And that's easy, because this is something that we don't do every day. We do once a year, maybe twice a year. and we do 200 meniscus. So they are used to some things, but this is different. You have to take care of that. And what Edmundo said, we have to prevent extrusion, and the physical therapy is key for that. I mean, it's very, very important to keep the patient very, very quiet in that knee and not moving very much for the first 12 weeks, for sure.
And can I just ask again, just back to the point of the biologics as it relates to the post-op stuff, is it routine to inject the knee with PRP or stem cell or one of them? Is that part of your protocol for sure? And if it's a stem cell, which one is it? Like what are you giving people? Because as you know, there's 6, 7 different types.
We normally, what we do is, I'll talk about PRPs and then I'll let you talk about stem cells. The PRPs, what we normally do is to apply it during surgery and right after the surgery, 2 weeks.
Okay.
That would be pretty much about it. And then you will have to decide if you go the route of stem cells, and I'll let Carlos talk about that.
We have been, we've been doing some research on meniscus and stem cells. Definitely stem cells that you would use in cartilage, and meniscus are from bone marrow, not adipose tissue. They have a much, much better genetic charge and load for that. Expanded cells between 10 to 20 million in one shot are good, but they die if you use them in surgery, and they're very expensive. So it's not a good idea to use them at that moment. So the ideal patient for stem cells that we would choose for stem cells, probably 12 weeks after surgery, would be the patients that have some kind of mild cartilage damage and a meniscal transplant. That's a crucial moment, because in that moment between the 6th and the 12th, 18th weeks, that's the moment where you really do need cells to go in there and invade. And at the very beginning, it's more a mechanical anchoring of the tissue, but then maturing the tissue, it's a little bit later. So we're not doing at the moment. We used to do a lot of meniscal transplantations with PRP. We don't do them anymore because of that. So when we do meniscal transplant, we tend not to do it at the moment, but more in the later period. And there's very good studies now about meniscus regeneration in stem cells, MSC, mesenchymal stem cells expanded, from the group from Barcelona, the group from the ITRT group. And that would be nice, because, you know, all my colleagues say, you are very good in research, but watch out. Don't you ever heal a meniscus, because I'm going to be out of business. So better be very, very careful with my meniscus, okay? So that's what's going to happen. And the truth is, Brad, that all of us that go to surgery, if we practice bad orthopedics and we operate only the MRIs, that's almost 25 to 30% of the patients that may have a very small, mild lesion of a meniscus that you could heal really with biologics. And that's the next movie. That's the next Star Wars movie that we're going to work with Edmundo. So we're going to be there but specifically for transplantations, I guess that I use them only in certain patients and later on, and probably PRP is good enough. We won't need a big investment with stem cells so far, unless you have cartilage lesions.
Now, since Carlos brought up a word that's near and dear to my heart, research, why don't we talk a little bit about that? Just a little bit. We have about 10 minutes left. What is the extent, or how would you characterize, Edmundo, Carlos, Octavio, and others on the phone, the quality of evidence right now for meniscal transplant? And I'll extend it further to biologics as it relates to, some of the knee pathologies. Do we have enough data? I'm guessing we don't, and we need more. But what is the body of literature? Like, is it, in terms of meniscal transplants, in terms of historical context, are we talking thousands of cases, hundreds of cases? What's been done?
I think the largest series are a couple of hundred of cases. It's not bigger than that. One of the better known surgeons on meniscal transplant is Juan Carlos Monjao out of Barcelona. As a matter of fact, I went and trained with him in order to do my first case. like they say in Canada, see one, do one, teach one.
Mm.
And he has done a couple of hundred cases. So there is not a big numbers. And perhaps it is the time to compare apples with apples and pears with pears in order to get the result that most kids want. We will be talking about that.
Right. Well, let me ask you this. I mean, has somebody done a review right now that's published that looks at the current body of published literature on meniscal transplants? Is that review already existing or is it recent?
I don't think so.
Okay.
I've seen some meta-analysis of meniscal transplants case series,
Right.
or court studies. They do exist. The results are kind of shady. They tend to one or other side. Depends on the group of study. But in general, they have good results.
Okay. Okay. So there's lots of opportunity. If you were to compare it, what would be the appropriate control? Let's say you're doing a study that's a control. Is the control do nothing, or is it maximize non-operative treatment? Because you're talking about some of these patients, they're too young for major interventions like a joint, right? So that's not going to be the comparator. What is it?
It will be something that you inject inside of the knee.
Okay. Right. So a knee injectable. Okay. Got it. And
Probably
I would say,
it.
just to answer the first question, probably the largest series were from 2009. And then Brian Cole and the group from Chicago, they had another good series that you can check on in 2015. And basically they are for lateral meniscal transplantation with dovetail or bony type of implants, and the results are pretty good. If you ask me about controls, then you have to go back to the first question of what's the population and who is the one that is the ideal candidate. If you want to compare one to the other, it would not be a case for an osteotomy. It would not be a case for a total. It would be a case, like Edmundo says, for other solutions, therapeutic solutions like injections. But you have to think that this is not too easy, Mo, because it's a very specific type of surgery that has a very precise indication, and in that case, it will be a winner. Yeah, so it's very hard to have a control, but as you see, not a lot of people are doing it. So you're going to have a lot of controls.
yeah,
So
that's
you can do that.
Yeah. I mean, the hard part right now is you believe, sorry, one point and I'll jump out. But the point you have here is the following. You have to convince, you have, decades of experience. You know exactly what you need to do. And now the goal is, if you want it widespread, there's going to be people all over the world that's saying, great, show me the evidence. That's what they're thinking. They're not looking at your decades of experience in the same way that your patients are looking at it and the outcomes. How do you convince a broader community that, this is a very seriously viable option? And what's the additional information you need, I guess, right now?
And that's
Show them the book.
From Canada point of view, just so that everybody knows, I can't inject any of these biologics, et cetera, into people's knees.
PRP you can. PRP, you just can't do stem cell.
Yeah. But so it's a great point. What's the trial and how do you convince?
I think the population is, and I'm sorry that I'm pulling in so much, but the ideal in my mind, the ideal research work would be take patients that have had a young patient with a total meniscectomy or a very large damage of the meniscus. And this is the patient that you can follow and do a case and control. And these are the two patients you could just follow until they're symptomatic, and then you can choose which way to go, a case and a control. But you're going to need years for that, years. So it's not easy. It's not easy.
Great. How many total meniscectomies have you done through the years?
Me?
No. Great. Patterson.
Who?
Who are you asking, Brad?
Me?
Brad, I'm sorry, Brad.
Oh, sorry. Total meniscectomies. I'm a trauma guy. I'm anything that I would have done would have been through watching the guys at Joe's do it. But I can tell you right now.
I can't remember.
I can tell you right now. So I'm not a knee scope guy. I'm a trauma guy. But I can tell you our knee scope guys are very quick to just debride the meniscus. They're not doing what you guys do. They're just very quick to do very standard old school stuff. Now they're not carving the whole thing out, but they're certainly not doing heroic measures to save it either. And I don't mean that in a negative way.
There are very good studies that show that even removing a teeny tiny little portion of the meniscus will create wear and tear.
Yeah, for sure. Yeah.
So if you take let's say 20%, 30% of that meniscus,
50%.
you're only leaving the rim, that's the ideal patient for a meniscal transplant.
Yeah.
But today we're in 2020. Save the meniscus.
Well,
So we're trying to do all the sutures we can, even if they're difficult, to try to preserve the meniscus and try not to progress to osteoarthritis. So still in places that they're doing a lot of meniscectomies, even partial meniscectomies, they're going to have to probably end up in a total joint replacement.
But
Now,
Dr. Uribe called it the menicide, el menicidio. It's like a homicide, the menicide, when you take out the whole meniscus. We don't do that anymore, but it happens. I mean, if you do a suture and it fails and it fails and it fails, and that has happened to us. You do a meniscal suture because it's a long, big piece of bucket handle. You put it back, and then you lose it in the second surgery. What are you going to do if you go for a third surgery? You got no meniscus. That's a meniscectomy. It's not your intention, but you have a 25-year-old kid, third surgery. What are you going to do? A total? You can't. A partial? You can't. An osteotomy? There's no deformity. That's a perfect patient. So those are the cases. Those are the cases that if you have more than 50, 60%, then you can set a cohort and starting doing the research and putting one arm or the other. But it takes time.
I'm sorry, just one more thing. Brad was asking about bioengineering tissue, meaning tissue, meniscus that is created on a lab and is made out of collagenous tissue. Well, it's actually from the crest of the rooster. That tissue can replace a torn meniscus, but you're going to have a good posterior core and an anterior core. Otherwise, you cannot attach it back to put its place because that tissue is very fragile on pulling. It's not like the surgery that you were seeing where you can pull and push and pull and push until we get it settled in their place. So there is a place for that engineering tissue, but you better make sure that you have a good anterior core and posterior core.
Man.
Listen, I am loving this conversation, but I'm also very respectful that, as you can imagine, an hour has flown by, and we can continue discussing. I'm sure we could keep going for another 2 hours if we wanted. But at the risk of letting everyone else get on with their evenings, I might ask, if I could, Dr. Berumen to maybe give a few comments, a few summary comments of this discussion, and then I'll ask maybe Brad to have a few closing notes. We have 3 quick questions to ask you as part of a poll at the end as well, and then we'll close out.
I think that if you ask me to say 3 things: 1, save the meniscus. 2nd, save the meniscus. 3rd, save the meniscus. When you are operating on a meniscus, always think about your hand and your thumb. So, and if you cannot save it, think about meniscal transplant.
Well, I thank you very much to Edmundo and Octavio, Carlos, Fernando, everybody who's been joining us. And I tell you, Edmundo, sincere thanks. You've really given me some stuff to think about with respect to my own young trauma patients as well. And I love just the conversations that you have when you get into these, outside of Canada and internationally, because the things that you guys are doing there are, some people aren't even letting us do. So it's just fantastic to hear what everybody's doing. And
that's why the name, from a galaxy not so far away.
Thank you so much.